Okay. Just a couple of housekeeping things. Um, my team went in the first round and been extremely generous and in a very good mood. And so I've decided that because that critical thinking writing assignment was an add-on thing that was thrown at us at the last minute, I'm going to provide them with the data, but I'm going to remove that from gradebook, and it will not affect your score one way or the other. For most of you, it's not really going to make a difference at all. For a few of you, you're probably like, great, but in any case, I'm taking it out because I don't think it's fair to really grade you guys and have it potentially affect your overall score in this class when it was something that neither of us were really expecting, and the fact that it was requiring me to use a rubric that's different than anything I've ever used before, and I actually had to consult with one of our faculty members who has used it before to kind of make sure we were on the same page. So rather than risking it being a grade robber for anyone, I'm just not going to count it into your grade. But I at least have the information so I can provide the dean and the powers that be the statistics that they're working on. So in any case, if you feel that you have a real issue with that not being counted, please contact me privately and we can work something out.
Could we get some contribution points just for the effort that we're putting in?
I will consider that. So you're catching me on a very generous. I will definitely consider that.
What was the question? What was our question?
Could we instead maybe get some participation points for that? So, this class is not typically a problem with participation like some of my classes. I'm very pleased, you guys. Even if you're not speaking, your head nodding, your eyes are open, you're engaged, you're showing that you're conscious, which is very reassuring. So anyway, that, I just wanted to kind of throw that out there, get that out of the way. If you have not contacted me with your topic request for your next paper, please do so ASAP, because I would hope that you are at least starting your research on that by now. So if you fall into that group of folks, there's a very small number, but if you haven't gotten approval for a topic, please contact me so that we can make sure we get that underway. All right. Today we get to talk about a collection of disorders or diagnoses that are at the same time challenging and somewhat bizarre and unusual. I have had some folks with some of these diagnoses, and the first time I'm like, okay, maybe this person needs to see a mental health counselor, only to find out through research that actually this could be legit. And so early in my career, I had some interesting cases. So today we're going to talk about, for lack of a better word, ear noise. Tinnitus, hyperacusis, misophonia, and musical ear syndrome. Tinnitus or tinnitus, you can pronounce it either way. They are both considered correct. The self-help organization, the American T Association, they pronounce it tinnitus, but most professionals will call it tinnitus. So, but either one is okay. And it is basically ear noise. It's the perception of sound in the ear or in the head when there's no external source for it. So I've had people describe their tinnitus as sounding like a sizzling sound, like bacon frying. I've heard it described as kind of a high-pitched sound, almost like constant chirping of crickets. I've heard it described as kind of a roaring sound, like waves hitting, the ocean waves hitting constantly. It can take any number of sounds. I've heard some people described as tonal. Sometimes it's pulsatile, where they perceive that it's almost happening in time with their heartbeat. In those cases, it usually is, and they usually have a big honking lomus tumor in their ear, which is an abnormal, it's a form of an AVM, arteriovenous malformation that forms in the ear, called lomus jugular tumor. And we do, you've seen probably, or you will see in your rotation, when we do a tympanogram on someone, and then we do acoustic reflexes. Well, the reflexes will look like an EKG tape, where you will actually see their pulse bouncing in it. And so that's never a good thing if you see that, because they're definitely going to need surgery. But anyway, so tinnitus is just, there's perception of noise in the ear, sometimes not exactly in the ear, but somewhere in their head, when there is no external source. Hyperacusis is an unusual sensitivity to sounds. Usually it's to loud sounds, and usually they are bothered by it at loudness levels that are not nearly as bothersome to most people. There's a child at my son's school who has severe hyperacusis, and so anytime that they're going to have a fire drill, his personal aide that's assigned to him has to be told ahead of time, and literally has to get him out of the building before that fire alarm goes off, or he's done for the day. So sensitive. Now, granted, that's a really loud, annoying sound. It bothers me. But there are many people who, sounds that you and I might find, it's kind of annoying, not something I'd want to listen to for a long period of time, but is extremely bothersome, if not painful to them. So that's hyperacusis, that abnormal sensitivity. Misophonia is a sensitivity and intolerance for a specific sound, and it usually doesn't have to be loud. A lot of times it's not at all loud. So there are people that have this sensitivity to the sound of people chewing, to the sound of breathing, just really oddball things. Anyway, very interesting. I've had couples in my office where one of them has misophonia, and 3 or 4 different things that the person does is bothersome. Like, when he's breathing, I can hear it, and there's this whistle or rustle, and it's driving me crazy. And when he chews his food, and I'm like, okay, so you want the guy to starve and asphyxiate, basically. Anyway, we'll talk about how we fix those things, because it's truly a legitimate thing, and the first time that you deal with it, you're like, okay. I saw some grins and giggles, and you're like, okay, what is going on here? I didn't go to school for this. Well, yeah, actually you did. Anyway, the last one is probably the one that's most bizarre, and it's really only recently, these bottom two, the misophonia and the musical instrument, really only in the past couple of years has there been much research done on these conditions, so that we can now objectively say, yeah, they really do exist, and yeah, there really are some things we can do about it. But musical ear syndrome, we think it's an aberrant form of tinnitus, but we're not sure. Basically, it's a form of an auditory hallucination where people will have the perception of music in their ear or in their head when is no music playing. And for some people, it's not just music generically or in general, it's a specific tune. I had a patient come in who told me that she wishes the woman in her ear who continuously sings Ave Maria would shut up. She heard that. I had another patient who constantly heard Christmas carols. And there was like a playlist of 4 or 5 of them. And one or the other of them was always going on. And so anyway, and the first time, because these are such low incidence problems, and it wasn't anything I learned anything about tinnitus, yes. A little bit about hyperacusis, but nothing about misophonia or musical ear syndrome back when I was in school. But by the time I went back to school and got my doctorate, 15 years later, yeah, then we were starting to hear stuff about it. And so, anyway, yes, there are some strange syndromes out there, and we're going to talk about them. So, tinnitus, the ear noise. We don't know for sure the exact mechanism, exactly what's happening. There are a couple theories, and I'm going to explain to you the one that I think makes the most sense to me, and that there seems to be more and more research supporting. But we also know that it can be exacerbated or triggered by certain conditions or exposures. One of the main triggers is, for lack of a better word, we'll say dietary or ingested triggers. These include things like caffeine, the nitrates and nitrites that you might find in processed or smoked foods, like bacon, sausage, and luncheon meats, things like that. Certain food additives like MSG, the sulfites that are found in things like red wines and certain cheeses can be triggers. They can be irritants that cause people either to have tinnitus or to make it worse. So what we have found is that I typically tell people, oh, and salt. Salt is another one. And aspirin. Anything that's potentially ototoxic. So I always review my patients' medications with them if they're here for a tinnitus assessment. Talk about their diet, and anything that we identify that maybe they have a higher than usual intake of, I ask them to try and cut it by 50%. Not eliminate it, but try and cut it back by 50%. And more than half of them, if they do that, will typically tell me. No one's ever told me, oh, it completely went away. But more than half of them have told me that, wow, my tinnitus isn't as bad. And if I give them the tinnitus handicap inventory, which is a patient self-rated questionnaire, they almost always have moved at least one level milder. So it really can make a difference for some patients. Now, if they have certain medications, we know it's going to cause it in the majority of people, and they may have no choice but to take, for example, some of the chemotherapy drugs. But in some cases, the physicians may have alternatives that they can try, and so I have worked with patients and their physicians before to try and change them to an alternate medication, and we have, in many cases, seen some relief. So typically, if they say that it started, I started taking this new medicine for my cholesterol and high blood pressure, and it started, right around that same time. Well then, let's check the meds. Sure enough, tinnitus is a side effect. So let's check with your doctor and see if there's something else we can try and see. And then they'll say, you know what, it's gone. We changed medication and it's gone. Okay, well then, problem. It's usually not that easy. We do know that in most people who have hearing loss, particularly high frequency hearing loss, tinnitus is very common. And so we know that there seems to be some connection with noise exposure and cochlear hair cell damage. How many of you have been to a concert and when you walk out, your ears maybe feel a little bit full, or maybe your ears are ringing a little bit, or you just feel like that's because you've been exposed to loud enough sound that you're getting what's called a temporary threshold shift. So basically those little hair cells that are normally standing upright and spiky are kind of bent over a little bit. And hopefully after about 14 hours of relative noise rest, they'll perk right back up. But if they started like this, maybe now this time they're like this, and then the next time they're like this, and the next time they're like this. And eventually they don't ever fully recover. It can be a cumulative effect. And when that happens, there's a mechanism that we think takes place that leads to tinnitus. But other ear conditions, people who have impacted wax sometimes experience tinnitus. It can come along with tumors, other neurological things, and it can be psychological as well. It could be what we call subjective tinnitus rather than objective. Things that are due to medications, diet, inner ear damage, those are all tend to be what we call objective. And if we were to put a probe microphone deep down or through the eardrum into the inner ear, we might actually be able to pick up true sound. And so it's objective, we can really measure it. Whereas the psychological ones, they are definitely subjective. No matter how sophisticated our measuring equipment is, we could go, we call it transtympanic, through the eardrum and actually listen with a very sophisticated probe, and we're not going to hear anything. Anyway, there are 4 main theories that are out there, and there is some research to support all of them. Like many things, I have a feeling that it's probably more than just one thing going on. The first one is called the misfiring theory. And what it can be likened to is, if you've ever heard of someone who's had an amputation that complains of phantom limb pain, where the limb is gone, but the nerve endings going out to there are still intact. But now they're no longer getting input, and they're not able to, provide output for movement. So the nerves are still there and intact, and intact, but they're not really doing anything. And the theory is that those nerves then misbehave and misfire, like, hey, we're still here, what about me? It's sort of like the annoying little kid who's not getting any attention. What do? They act up so that someone pays attention to them. And that's kind of sort of what it's like. So what happens is that when there's damage to the inner ear, to the cochlea, typically the nerve itself is fine. That's why we can use cochlear implants successfully, because the nerve is fine. It's a problem with getting the nerve stimulated. Well, when those hair cells are damaged and they're not providing stimulation to certain sections of the auditory nerve, but the nerve itself is still intact, and there are little synapses that are basically no longer synapting to anything, they misbehave. And they say, hey, we're still here. What about us? And they may be irritated by the sound vibrations that are coming in that bypass them because they're not tuned to their frequency. So that's kind of what it is. It's the auditory nerve misbehaves because there are portions of it that aren't getting stimulated because they're hearing loss. That's the easiest way to think of it. Then there's one that's called the outer hair cell, inner hair cell discordance theory. Basically, what it says is that there's asymmetrical damage to the inner versus the outer hair cells. And so the outer hair cells may still be intact, but the inner hair cells aren't. And so the sound basically kind of bounces around in there, or vice versa. Could be the outer damaged and the inner's not. But basically, the hair cells are not working in conjunction with each other, and so sound just kind of goes around. There is another theory. It's probably, at this point, the most weakly supported of the four, called the spontaneous otoacoustic emission theory. And you've heard me talk about otoacoustic emissions before. It's a form of testing that we can do, and basically we put sound down in the ear, and then we're listening for echoes to come back to make sure that the inner ear is working properly. So we can indirectly measure hearing sensitivity. Well, this theory says that for some reason these otoacoustic emissions are spontaneously occurring. Well, to me, that'd be sort of like saying that your car is spontaneously emitting exhaust when it's not turned on. How is this possible? You kind of have to have it turned on in order for that to happen. But there are those who believe that it just does happen. That's why. I think that if you buy that, then why don't you just buy the misfiring theory? Because at least then there's an actual mechanism. It's like, the spontaneous, it's like it's magic. And I had a problem with magic. Whereas I can wrap my brain around the fact that, oh, well, yeah, the nerve is still intact and it's misfiring because it's not getting properly stimulated. But anyway, yes.
Did you say that otoacoustic emissions are like the echoes that are coming back from sounds that are coming in? That's what's causing spontaneously with no sound coming in?
Correct.
Okay.
Otoacoustic emissions are the echoes that
Yeah.
occur in response to a sound. That theory is saying that those are happening spontaneously without necessarily being in response to that sound. It's not because, think about it, we're rarely in complete and utter silence, so there's always going to be some sound coming into our ears even if we're not aware of it. But typically, tinnitus is fairly consistent for people. Well, how often is that exact sound coming through? Not very often. And so I have a hard time wrapping my brain around it. Jastroboff has proposed a theory that kind of combines the misfiring and the discordance theory, throws in maybe a little bit of perceptual psychological component as well. And it's called the neurophysiological theory. And basically it says that there are some neurophysiologic changes that have occurred either in the nerve itself or in the inner and outer hair cells, and combined with a person who is maybe predisposed to problems with adjustment, problems with sensory processing, they experience tinnitus. It kind of makes sense because Jastroboff has come up with a specific treatment approach that incorporates kind of desensitization and counseling as well as sound therapy to treat tinnitus, and it does seem to work for some people. It also uses some kind of bizarre methods that, if you saw the King's Speech, I think, are sort of like some of the voodoo and marbles and stuff that they had the king actually clinics where that's all that they do is this tinnitus retraining. So there's definitely something to it. But again, I think for some of those, it's more the power of suggestion that's actually there. But that's just my opinion. So what do we do if we have a patient who is complaining of tinnitus? We have an actual assessment that can be done. Some of this is stuff that speech pathologists can do, and you may be actually called upon to do that depending on where you work. And so I'm going to show you the tinnitus handicap inventory. And basically what happens is the patient reads the statement and answers yes, no, or sometimes. What they don't know is a yes is a score of 4, a sometimes is a score of 2, and a no is a score of 0. So they go through, and the letters over here tell us they correspond to, is it something that's cognitive, is it something that's emotional, is it something that's physical? And so that we know where do we need to be focusing our attention. But then we take their totals, their total number of 4s. This one gives them a 3. The one I usually uses a 2. But anyway, so then you tally up their total score, and you give them a grade. So if they have a score between 78 and 100, then they are considered to have grade 5 tinnitus, which is considered catastrophic. These are people, and there are folks who literally are on the verge of or have attempted suicide because the noise in their ears is so debilitating and so bothersome that they feel like they can't go on. I've actually had a couple of patients that were that severe. Severe is 58 to 76, moderate, mild, slight. Dr. Kelly and I, because she's been exposed to kind of the theories behind it, but hasn't really worked with it a lot. And while I'm no expert in it, I have worked with a number of patients. So she and I tag teamed on a patient that she had gotten because A, she wanted to learn a little more about it, and then B, if this lady needs follow-up, there's now 2 of us who are a possibility, so she doesn't have to, like right now, I think they're booking me for the week of finals. So I'm like booked 6 weeks out, and most of our audiologists are like that. So this way, if there's more than one person familiar with the case, it doubles their chances of getting an appointment in less than 6 weeks. But anyway, so we assessed her, and her initial score on the tinnitus handicap inventory was, I think 72, 73. So she was in the severe range. She's a preschool teacher, and her hearing is relatively normal. She has a very slight high-frequency hearing loss in both ears, but she also has this funky notch, like we talked about notched hearing losses, which we typically see in that like 3, 4, 6,000 hertz range. Well, hers is like 750, 1,000, 1,500. So it's that notch, but it's moved. And so, anyway, really that was her main thing. She's not really, and she says that she struggles at times to not necessarily to hear, but to understand, because the tinnitus is distracting her. She doesn't really feel like it's because of the hearing loss. And actually, when we did word testing with her in quiet, her word testing, her speech discrimination scores were so, and even if we put in a little bit of background noise, she was still like 96%. So I do believe if she's struggling to understand, it is something other than her hearing levels. But anyway, so jumping ahead a little bit, there are devices available that look like hearing aids. They're called tinnitus maskers. if you have a patient where exposing them to particular types of sound suppresses their tinnitus or their awareness of their tinnitus, then they're a really good candidate for a masking for sound therapy. And that happened with her. We went through the process, and so we then started doing some matching, and we said, okay, we're going to put some sound in your ears. Tell us if you hear a sound that's similar to the tinnitus in your ears. And so we'll try warbler tones, we'll try narrowband noise, we'll try pure tones, we'll try pulse tones or pulsed noise, until we get, hopefully, a frequency that's close to what theirs is like. And she was really difficult. So we did, the closest we got was like a narrowband noise at like 1500 hertz, which really was probably, had components everywhere from about 900 hertz to about 1700 hertz. And especially if we warbled it, so that it was like that sound. So it kind of was a shaky, tremorous sound. And we just let that go, play continuously in her ear for about 5 minutes. And then we took it away. And it wasn't loud. It was just loud enough for her to really be aware of it there. And then we took it away. And you could see the look on her face. That she said, it's not completely gone, but I almost have to struggle to hear it. The tinnitus. It's like, okay, this is a good sign. So we got her, one of the hearing aid manufacturing companies has come out with a line of tinnitus products. They have one that's just the tinnitus masker. Then they have another one that's a hearing aid with a built-in tinnitus masker. So like for someone who maybe has more hearing loss, so they need a boost of some sounds, but they also need this masking, we can do that. It's called Zen, for sound therapy. But anyway, so it's a really hokey name, but it does seem to be a really good product. And so we fit her with it, and she's been using it for a month, and she came in Monday night with her checkbook open, and she's like, ready, definitely want it. Like, well, wait a minute. So we had her retake the tinnitus handicap inventory. She scored a 34. So she had dropped 2 levels after just a month doing nothing but using this. I mean, she didn't do any dietary changes. We didn't really do any counseling with her. We did have her journal. I always like my patients with tinnitus to journal and jot down every day something about their tinnitus. Good, bad, where was the circumstances. She claims that she did that, but she forgot to bring it with her. So I'm a little skeptical that it didn't really happen. But the important thing is the masker seems to be working, and she improved by 2 levels. To get a drop of 2 levels in literally 4 weeks' time is pretty amazing, particularly with just sound therapy and nothing else. So I was very, very pleased. But in any case, it's nice because you can give this particular instrument to the patient repeatedly and track changes over time. And it can be very reaffirming or reinforcing to them that what we're doing is helping when they see these differences in scores. Okay.
So when the mask is working, does it take the same sound and find a different sound to input it to offset it, or does it?
That's a very good question, and we have options with the Zen to Go, which is pre-programmed, so we supply them with their hearing levels and everything, which is what we chose for her because we wanted the simplest, least expensive thing. You have 4 4 settings. Mute, so it doesn't provide any, so you can be wearing it, but it's not doing anything. There is tone. There is noise. And there is a combination of noise and tone. But the tone is not a continuous pure tone. It is, like you said, it actually is a warbled tone, but it's warbling between 2 different frequencies, so that there's like a high and a low, so it's more like a, which to me, it's like, it would be like having a horror movie, background music playing in my head, but that's the one that she really likes. I really thought she was going to go with the narrowband noise. I really did, because that's what she seemed to react to the most in the assessment. But in the process of, she has a little remote that she can adjust the volume louder, softer, and she can also adjust what the sound stimuli is. And in playing around with it, she liked the tones, and she liked it 2 decibels louder than what the predictive preset volume is.
So it's just very individualized for every person.
I'm sorry?
It's just individualized for every person. It's not the same.
So the nice thing is she can switch it if she wants, and if it starts losing its effectiveness, we can come in, she can come in, we can hook her up to the computer, and we can actually make adjustments. Like we can shift the frequency range, we can increase the volume, lots of things. So, but the good thing is, for her, it really seemed to work. So anyway, so what happens, we do some sort of a questionnaire. I think that's really important. And it's also great because that becomes your outcome measure. We talk about the importance of measuring outcomes. Well, if you can show that the patient improved from like a 72 to a 34, that's a dramatic improvement. So, but anyway, typically we're going to do a standard audiological evaluation, and if we have the capability, and we actually do downstairs, we'll do the extended high frequency. So typically we stop at 8,000. We'll do 10, 12, and 14,000 hertz as well. Sometimes that's where the hearing loss is. And so then we try and do the pitch matching and the sound matching, and then we do a loudness matching so that we make the sound that we're presenting that we've matched tonally and acoustically, and say, okay, now tell us when you no longer hear it. Okay, now tell us when you just barely hear it. And usually we're within and we'll usually do 1 dB increments, and usually we're within a plus or minus 3 dB of their threshold. That's closest to that tone, which is really kind of cool. Then we know, we feel pretty comfortable. This is probably due to the cochlear damage. Which is the theory that I like. Totally makes sense. I like it when my test results support my philosophy. I'm biased that way. But anyway, so we do these matching levels. Then we also try and establish their loudness discomfort levels. Why do we do that? Because guess what? A lot of people who have tinnitus also have hyperacusis. So we want to find out what sounds and at what levels things become uncomfortable for them. We will then try and do some masking of their tinnitus using either broadband or narrowband sounds with a minimum level. So we try and find where are you just barely aware that the sound is there. So you're almost having to struggle, but not quite struggle, to be aware that, ooh, we're putting sound in your ear. And then we let her rip. That's when we go for 5 minutes and then see if we can suppress it at all. And so that's basically the process for assessing tinnitus. There are, like I said, 2 main outcome measures that you can use: the tinnitus handicap inventory or the tinnitus reaction questionnaire. There are 25 items on the THI with 3 different Likert scales. 0, I think the new one, that one that we just did, is the new one is revised. 0, 3, and 4. At the time, the previous one, I know the ones, the copies that I have in my office say 0, 2, and 4. But in any case, so then we convert it to a grade depending on their score. The TRQ has 26 items and it's a 0 to 4 scale. Not at all, a little of the time, some of the time, a good deal of the time, or almost always. And it provides a score of 0 to 104. And they say that you can then use it to estimate a grade, but unlike the tinnitus handicap inventory, it doesn't actually give you specific ranges for those different grades. So you can guess which one I typically use. Clear. Audiologist to me likes the black and white world, where it's this or it's that. So anyway, then that becomes your baseline measure, and it becomes an outcome measure. Okay. So how do we treat it? We talked a little bit about sound therapy, symptom management, where we do diet and lifestyle changes. We look at their meds, we look at their intake, things of that nature, and anything that we can adjust, we do. Some people are notorious for engaging in recreational activities that are likely to induce tinnitus if they don't use proper hearing protection. And so we get in our little soapbox about that. We talk about the use of personal hearing protection if they are engaged in activities that involve lots of noise. If they are shooters, for example, we probably recommend the impact shooters. Hearing protection, where they actually have a little flap that just the sound, the detection of the sound wave coming in closes a flap, which shunts the noise out, and then after a short period of time, unless there's continued sound pressure against it, the flap opens back up. So they can be listening for that buck out in the woods, and when they hear it shoot, and as they do, it closes, and then because they've only shot once, it's going to flap back open, and they can hear where it fell in the woods. So anyway, there's pretty sophisticated hearing protection. But maybe they are someone who always walks around with earbuds in their ears, and I can hear them here, and they're as far away as Amanda is over there. Then you can smack them upside the head and say, turn it down. Remember, if someone can hear it an arm's length away, it's too loud. Turn it down. Anyway, and then we give them the kind of cheesy ASHA, listen to your buds, informational thing that talks about how to safely enjoy your music. But anyway, so we work on them with diet and lifestyle changes. Those are the easy ones to do. If we need to work with their physician about medication management, we will do that. It is not our scope of practice to say this medication is causing the problem and we need to change it. No, that's the physician's problem. But we can say, hey, patient's symptoms seem to be closely tied with when they started taking this medication, and according to the information from the manufacturer, tinnitus is a possible side effect. Is there some other med or another class of meds that you could try because this person grade 4 tinnitus patient now and is contemplating rusty razor blades, and I'd really rather that not be the case. Anyway, so we can do that. Then we can engage in tinnitus retraining approaches. It's typically a 3-pronged approach. One involves the tinnitus masking that we talked about. Another is what's called sound enrichment. For most patients with tinnitus, silence is their biggest enemy. To the patient, they will always tell me, my tinnitus is so much worse at night. What happens at night in your house? There's nothing to distract your brain. So, we always counsel them. Silence is their worst enemy, and because of that, they need to constantly surround themselves with soft, pleasant, or at least not obnoxious sounds. Sleep with a fan on. Get one of those nice environmental sound machines. My son sleeps to the sound of ocean waves every night, and he's such a happy camper because he's a very light sleeper. And he will wake up at the drop of a hat. And I think part of it's our fault because we were like those really dorky first-time, slightly older first-time parents that decided that we had to get the baby Einstein and we had to get the baby Mozart. And so the kids, well, first of all, he spent the first year of his life living on a very busy street in Guatemala City where his bedroom was open because it's always like spring or summertime in Guatemala, and so they never use air conditioning, but because it's always like 78 to 82 degrees year round. And Guatemala City is a city of like 8.5 million people. It's very noisy. So the kid grew up the first year of his life with an open window next to his bed with sounds of basically a city, the size of Chicago outside, and then he gets home with us and we're playing baby Mozart games, all night long for him on his own little CD player that's on repeat in his room. So no wonder when he's like 4 and we're like, okay, it's time to get rid of this stuff, he suddenly can't sleep because every little sound is waking him up. Well, he always had something to mask it out. So when he was about 6, we had him. So environmental sound machines. He sleeps very well. So we can recommend that. I've told people, if they don't want to invest in that, okay, well, do you have an alarm clock? Is it a radio alarm clock? Okay, great. Turn it to the AM band where there is nothing and you just get some static. Turn it down low. Most alarm clocks like that have also like a sleep timer on it where you can set it, it'll play for a certain amount of time and then go off. And if they don't, you start talking about that $29.95 at Bed Bath & Beyond for the environmental sound machine suddenly doesn't sound like such a big deal after all, and so they'll just go do that. But anyway, so we work on that sound management. The other thing for the sound enrichment, then we typically will work on behavior management. Most patients who have tinnitus, they are going to need some behavior management. They are going to need to learn and that, a lot of that has to do, and it's one of the reasons why I have them do journaling. Because then they can vent, they can see patterns, and a lot of times there'll be patterns that they were totally unaware of where their tinnitus is worse. And, on the one day a week where they're not at their regular office, but they're commuting to a remote office, and so they have a 75-minute car ride each way to and from work. Gee, did you notice every Thursday when you're making that extra commute, you're describing your tinnitus as being worse? So what can we do about that? Maybe it's not an option to change how they work that day, So then we have to come up with some coping strategies. Get a book on tape, or on CD. Something. Do something. So we teach them that they're in control. Because typically what's happened, by the time they reach us, they've been to their primary care physician and maybe an ENT, both of whom said, well, just tinnitus is just something you have to learn to live with. Believe it or not, yes, even ENTs are still not completely educated on the fact that, yes, there are things that can be done to treat tinnitus. And so typically just having the assessment and us being able to talk to them so much about it, they probably already dropped one level on the tinnitus handicap inventory because they've just been so used to being told, oh, there's nothing that can be done, to suddenly find out, oh my gosh, there really is something going on here, and yes, there's something we can do about it. They're so relieved. But in any case, so it usually, tinnitus retraining involves a three-pronged approach: masking, sound enrichment, and behavior management. For some people, you may only do one, you may only do two, but for most of them, they need all. There are cognitive behavioral therapies that are available for some people, particularly the ones that are at the catastrophic level. They are probably going to need psychological counseling, and typically a cognitive behavioral approach is what works. For some people, biofeedback and other types of counseling and psychotherapies. Like I said, the maskers and sound generators alone for some people is enough. And for many people, hearing aids. A lot of my patients will come in and they're there because they have a problem with their hearing. And they'll just mention in passing that they have hearing aids. And unless they're really ranting about it, I'm not even going to touch it. I'm not even going to go there with them. But it's interesting because, and this is further support for my philosophical bias, is when we fit them with hearing aids that are appropriate, they'll come in and say, you know what, doctor, the strangest thing, I don't have that ear noise anymore. I wonder why. Because we're stimulating a part of the auditory nerve that wasn't getting properly stimulated before, so now it's no longer acting up. It's getting the attention it wants and deserves. You see why I really feel like this misfiring theory really makes sense? Because my clinical experience is telling me, yeah, it makes sense. Because just putting a hearing aid on someone and providing them with sound stimulation that they weren't getting shouldn't do jack for tinnitus unless the tinnitus is related to that auditory deprivation. Anyway, so that can really help. I have seen, and statistics, and I would say my own experience backs it up, that providing people with hearing loss that have tinnitus with appropriate amplification, about 80% of them will report noticeable reduction in their tinnitus. Not elimination, but noticeable reduction. Okay? All right. So hyperacusis is abnormal sensitivity to sound. It is real. There are a lot of things that can cause it. It happens a lot in people who have migraine disease. Please do not be fooled into the misconception that migraine equals headache. Migraine is a multifocal disease process or disorder. There are many people who have migraine that have never had a headache in their life. Now, most people who suffer with migraine, they do have a headache component to it. But there are a lot of other components. There's photophobia, which is sensitivity to light. There's the hyperacusis, sensitivity to sound. Because what happens, if you know anyone or if you've ever had a migraine headache yourself, what do you want? You want to go to a dark, quiet, cool place. You don't want any light. You don't want any sound. You want something nice and cool. And you want to be left alone. And that's because it's a multifocal condition. People who have Meniere's often have tinnitus and they will often have hyperacusis as well, even when they're not in the midst of an episode. People who have TMJ dysfunction, temporomandibular joint dysfunction, often have hyperacusis. People who have facial nerve dysfunction, where they have an absent or an extremely elevated stapedial reflex, when we do acoustic reflex testing, it's really interesting to me. Most of my patients that have tinnitus and hyperacusis, I will frequently see that they have absent or very elevated stapedial reflexes. Well, what does the stapedial reflex do? What's it supposed to do?
Isn't that when, doesn't that one block loud noises from?
It absolutely does. It squelches, it stiffens your middle ear system in response to loud noise. So basically it squelches and causes a reduction in loudness. Well, guess what? If your stapedial reflex is gone, or it doesn't kick in until the sound is exceptionally loud, then guess what? Your perception of what's loud is going to be jacked compared to everyone else's. So it shouldn't be a major surprise. So anyway, it happens a lot. It happens often after noise exposure. You walk out of that concert and your ears are kind of ringing and everything, and then you get in your car and the radio's on and you're like, and you have to turn it way down because, and yet you were listening to it and it was comfortable for you on your way into the place. Here is, I hate to break it to you, a gremlin did not come in while you were in that concert and jack up the volume. And nowadays you can know that because most of the time if you try to adjust the volume, it's got a number or a slider bar that shows you, and you can know that's exactly where it was before. You're just more sensitive to it because you've been exposed to noise, and now your ears are super sensitive. If there is damage to some of the efferent fibers of the cranial nerve, we've done ABR testing and have found that some abnormalities there. Folks have hyperacusis. It can often happen after a brain injury, and in a lot of cases we just don't know. But those are things that we know for sure are associated with it. One of the interesting things is 85% of people with hyperacusis also have tinnitus. So the two conditions happen a lot. Now, it's not the reverse. It's not that 85% of people with tinnitus will have hyperacusis. No, because most people with tinnitus don't have hyperacusis. But if they have hyperacusis, the vast majority of them will also have tinnitus. There have been some really interesting surveys done, both here in Scandinavia and in Germany. Gee, I wonder why, because those are the three places where most hearing aids are manufactured. So it's where the most. I'm surprised that Australia's not in there too, because Australia is like huge for hearing, but they are really big into the cochlear implants. Most of the cochlear implant companies are there. But in any case, they have found that there's overall about an 8% rate of the population has hyperacusis, and it's slightly more common in women than in men. It's a pretty high number. Because when you consider that, depending on what statistics you look at, anywhere between 10 and 17% of people have hearing loss, 8% have hyperacusis. It also is extremely common in children who are on the autism spectrum. So just be aware of that. Your kids who are on the spectrum are very likely to have pretty strong reactions to loud sounds. Okay? But we know that they have, in general, a sensory system that's differently wired. So it shouldn't be a huge I've actually seen statistics looking at that population that's well over 50%. 50% is like the low end of the statistics I've seen, and I've seen statistics as high as like 80% of children on the spectrum will have some degree of hyperacusis. And if they don't have hyperacusis, they're going to have photoacusis, where their sensitivity to light. Okay? All right. So how do we treat it? Typically, it's treated with medication. Prescription of anti-anxiety and antidepressant meds can help. If they have migraine, there are medications that are becoming more widely used and successful in treating migraine. Those can help. Baclofen, which is a muscle relaxant, has been showing some promise. And then some anti-seizure medications have also shown themselves to be somewhat helpful. So medications may be the answer. Avoidance. The kiddo at my son's school, we moved him. I have families where they can't go if there's going to be fireworks, or they can't go to a wedding reception or someplace where there's going to be lots of music. Or they have to avoid those, or they provide them with earplugs to try and reduce the exposure. Some people who have hyperacusis have successfully been treated using some of the techniques that we use in tinnitus retraining, where we basically gradually jack up the loudness and expose them to it for a period of time until they're about ready to come through the little window at us, and then we remove it, and you can then put them on a home program where they gradually increase the length of time that they're exposed to sound, gradually increase the loudness, and over time you can sometimes see that they build up tolerance for it. And then again, psychological cognitive behavioral therapies are sometimes done. Misophonia. This is when they have that abnormal sensitivity to specific sounds. We really don't know a whole lot about the mechanism. Research has suggested things as diverse as, they all seem to have some sort of neurological component, but it can be as diverse as abnormally strong connections between the limbic and the autonomic nervous system. They've done brain mapping where they've seen some kind of aberrant, not typical pathways and connections between some of the auditory centers. So basically, we know there's something, they're differently wired. It really is real. They're not nut jobs. There really is something different in their wiring. We're just not exactly sure the mechanism. What's interesting is, though, that the vast majority of people who have misophonia also have a mood or anxiety disorder as well. They typically do have some sort of psychological diagnosis as well, and that's why for the longest time people were writing it off that it's all up here. Well, no, yeah, it is all up here in the brain, but there is an extremely high incidence of mood and anxiety disorders amongst people who have it. There's also about a 60% incidence of tinnitus. So again, it's not that 60% of people with tinnitus have misophonia, no. But more than half the people with misophonia also have some tinnitus. So guess what? Just like with our hyperacusis folks, sometimes just treating the tinnitus will result in a reduction in their symptoms of misophonia. It usually happens late in childhood or adolescence. Very rare early in childhood. very early, very rare in the elderly. It's usually going to have a late childhood, early adolescent onset, where it's usually going to have like a middle adulthood onset. Those are there's like two peaks. Okay. So treatment avoidance is the biggest and easiest treatment. So using masking or using earplugs. Again, anti-anxiety medications can help, and then desensitization, where you pair pleasant sounds with the annoying sound that's bothering them, and hopefully over time it'll work. There's not a lot of research to back that up, but people are still doing it because some people are kind of at their wits' end about it. I mean, if you have to go in another room every time someone's eating something because you can't stand the sound of it, you're probably going to be willing to try different things. Typically, cognitive behavioral therapy is the most successful. I've also had a couple patients who told me that they underwent hypnosis, and that hypnosis really worked for them. If it doesn't, find something else. Okay? The last one is musical ear syndrome. And this is when the person truly has the perception of music. Playing in their head. There have been a very small but significant number of cases where there's clearly documented some sort of a vascular event in the brain, like a TIA. And it's in the auditory cortex, where we know it happened, and boom, now they have this. It's also been reported in people who have long-standing auditory deprivation due to hearing loss. But we don't know for sure. Some people are saying that it's an aberrant form of tinnitus, but there's no one cause you can't pinpoint that explains it in everyone. It is more common in older adults than in any other age range. I've only seen a very small handful of patients with musical ear syndrome my entire career, and the youngest one was 72. It is more common in women. I've never seen a man with it. My experience backs that up. It's more common in people with documented hearing loss. All of mine were patients who also had hearing loss. And it's more common amongst people who report tinnitus, and all of my patients reported tinnitus. Because when I asked them about it, I said, oh yeah, I hear, and it was a song. And I'm like, what? But yeah, so for them, their tinnitus was a particular tune or playbook of tunes. So anyway, so how is it treated? It is difficult to treat because a lot of times they have been told, usually by their physician and their family, that they're crazy. So they're really often embarrassed and don't even tell people that because people look at them like I did the first time. I was like, what? And that's unfortunate. So my suspicion is that this is a condition that probably is more widespread than we know, but there appears to be such a personal stigma attached to it by the people who have it, that they're not willing to talk about it. But typically, actually in every case, the way that I found out that they had it was when I was talking to them about their tinnitus. And then they all, well, yeah, I have, and I usually refer to, do you have any ear noise? And they're like, oh, yeah, I kind of do. And I'm like, well, what does it sound like? And then they'll tell me. Or usually they'll say, you're going to think I'm crazy, but, so anyway, first thing you got to do is reassure them. Or if they are, this is not proof of it. And I've often said that to my patients. And that really breaks down the barriers. You're like, okay, they really believe me and they're willing to kind of joke around with me about things. Okay, fine and we're comfortable being goofy with kids, but don't be afraid to goof with your adult patients. Sometimes that is the most huge icebreaker and stress reliever that they're going to have in their entire week, and they're going to be so grateful for it. So anyway, so reassure them, create, this is real, we have dealt with it, it's complicated, you don't have all the answers. Typically they are going to require some counseling. Every single one of my patients, just like the recommendations, they do require counseling because they typically do have a high level of anxiety. They often have a lot of guilt and shame and some other things that they need to deal with. They may benefit from anti-anxiety medications. And then, again, some of the things that we do for tinnitus retraining, Vasper's, sound therapies, have all shown to have at least some degree of success. I was at a conference where one of the presenters said, yeah, I had a patient who we did sound retraining therapy and tinnitus Vasper's, and when she came in for her first follow-up, she's like, well, it didn't go away, but now it's a different song. And it was one that she actually liked, because apparently the one that she'd been hearing before was a song that she didn't like, and I guess it was something related to, it was like a song that was like their song when she was dating an ex-boyfriend back when she was younger, and so at least now it was like, I think he said it, that she said it was like some Benny Goodman kind of upbeat too that she really liked, so she wasn't as bothered by it. But anyway, you truly can, when you're dealing with folks with hearing impairment, see just about everything, whether it's cockroaches crawling out of their ears, green, letting look at discharge on their ear holes and their hearing aids, where they bring it to you and say, here, there's something wrong with this. Any good things. Yeah. Inside